Today in the topic of clinical neurology, we are going to discuss an important topic called as epidural hematoma. So before we go into the concept, it is important to know about what exactly is called as epidural space. So we can see the beautiful image here. In this image, we can appreciate the scalp, right? And in the scalp, we could also see the periosteum, which means the cranial wall, that is cranial bone. And just beneath the cranial bone, we can also appreciate meninges. So what are meninges? Meninges are nothing but called as protective covering of the brain and the spinal cord. And these meninges are made up of dura mater, which is the outer one, arachnoid matter, which is the second one, the pia mater, or the deeper one, right? So like this, we have totally three coverings called as meninges. So what is the outermost layer of the meninges? Dura mater. So dura mater is the outermost meningeal layer that covers the brain and the spinal cord, along with other two layers. So if you concentrate on this image very clearly over here, if you see this image, so what is the dura mater here? So this is the dura mater, right? Can you see the dura mater? Yes, we can appreciate the dura mater. I think you can also see very clearly that this is made up of two layers, right? The outer one as well as the inner one, right? So this is called as outer layer and the below one is called as inner layer, right? Outer one as well as inner one. So remember, dura mater consists of two layers. The inner one, right? This is the inner one. We can appreciate very clearly this one. This is the inner one. This part we can say is called as meningeal layer. And the outer one, this part, outer one is called as periosteal layer. Inner one is the meningeal layer and outer one is the periosteal layer. And the space between these two, you can see a potential space which is present between these two, right? So here, this one, or we can say the potential space which is present between these two is called as epidural space. So epidural space is the space between the two layers of the dura mater, right? And this space exists around both the brain as well as around the spinal cord. So this is called as epidural space, right? Yeah. So after knowing the epidural space, let us concentrate on the epidemiology of the epidural hematoma. So epidemiology is what we are going to discuss here. Epidemiology. So concentrate on the points here. It is more commonly seen in males when compared to that of females, and the male-female ratio is 4:1, right? Concentrate on this. Male is to female ratio is 4:1. Male-female ratio is 4:1. And what would be the peak incidence of this condition? Peak incidence. So peak incidence is seen between 20 to 30 years of age. Epidemiology, that is, the male-female ratio is 4:1 and the peak incidence is 20 to 30 years of the age, right? Now let us concentrate on etiology and pathophysiology, right? So etiology and pathophysiology. This is what we are going to discuss. So etiology and pathophysiology is very, very important for the examination point of view as well as to understand the concept. So as we already know that epidural space is a potential space between the dura mater as well as the calvarium. or we can say the dura, between the two layers of the dura mater, we can say. So how these epidural hematomas are formed? And these epidural hematomas are caused by the blunt trauma to the head. So what will be the most common cause over here? Concentrate on these points. What would be the most common cause? So the most common cause is blunt trauma. Blunt trauma to the head. So this blunt trauma to the head is most often associated with the fracture of the temporal bone. So this is also very important for you to appreciate. So because of this, what will happen is there will be a fracture. There will be a fracture of the temporal bone. Right? So by seeing this fracture of the temporal bone, immediately one point should strike to our mind over here, that the impact is over the lateral aspect of the skull. Right? Whenever we are talking about the fracturing of the temporal bone, most often during the falls or fightings or assaults, so generally what happens is the impact is more commonly over the temporal bone. So that is the reason there will be a temporal bone fractures. So that's why what we can say over here is, so skull fractures are present in 75 to 95% of the patients. So as we already mentioned about the fracture of the temporal bone, so remember this point here, skull fractures. Skull fractures are seen in 75 to 95% of the cases. And what would be the most common bone to get fractured during this impact? It would be the temporal bone, right? Yeah. So whenever there is a fracture of the temporal bone, remember that at the temporal area, the important artery which supplies the vast majority aspect of the meninges is the middle meningeal artery. So if you know about the anatomy here, we have three meningeal arteries: anterior meningeal artery, posterior meningeal artery, as well as middle meningeal artery. So middle meningeal artery supplies almost the greater part of the meninges. So whenever there is an impact over the lateral aspect of the skull, that is over the temporal bone, exactly at the temporoparietal junction, the bone to get fractured is the temporal bone, and the artery to get involved in the rupture is the middle meningeal artery. So it is very important point for us to write artery. Artery. So what is the artery involved? Middle meningeal artery. So this is very important point, guys. So middle meningeal artery is involved. So middle meningeal artery is the one which is going to get ruptured. So whenever we speak about this middle meningeal artery, another important anatomical link also we should give it over here, that which foramina is associated with the middle meningeal artery, which means which foramina accommodates this middle meningeal artery. It is the foramina spinosum. So concentrate on this point once again here. It is the foramina spinosum. So this is also important MCQ point. So foramina spinosum is the one which accommodates this middle meningeal artery. So what are the points we have discussed till now? Most common cause is the blunt trauma, mainly because of assaults or anything. And due to this, there will be a fracture of the temporal bone. So because of the fracture of the temporal bone, what will happen is there will be a rupture of the middle meningeal artery, and anatomical link, if you see, middle meningeal artery passes through the foramen spinosum. So because of this rupture of the middle meningeal artery, what would happen is resulting in the hemorrhage over the cerebral convexity. So this is the cerebral convexity. So there will be a hemorrhage over the cerebral convexity, that is in the middle cranial fossa. So concentrate on this point, guys. So another beautiful picture we are seeing here. where exactly you can see the hematoma here. So we often use two different terminologies over here. Sometimes we call it as hemorrhage and sometimes we call it as hematoma in the middle cranial fossa or anything. What exactly is the difference between this hematoma as well as the hemorrhage? It is important for you to know. Remember the point that hematoma usually describes bleeding which has more or less clotted, which means solidification of the clotted or solidification of the blood, we can say. So that is called as hematoma. But what exactly is called as hemorrhage? Hemorrhage actually signifies the active as well as ongoing bleeding. So sometimes both may exist at the same time, right? There will be an ongoing bleeding as well as there will be a hematoma also. If the bleeding stops, there will be only hematoma. So that is the main difference between hemorrhage as well as hematoma. Some of the authors mention this condition as epidural hemorrhage, or we can also mention it as epidural hematoma. So whenever we talk about the location, so what would be the most common location of this epidural hematoma, guys? Most common location will be temporoparietal junction. Remember that point. Most common location will be temporoparietal junction. So why this location is extremely important here? Because it is the location of the middle meningeal artery. So because of the impact is over the temporoparietal junction, middle meningeal artery will be ruptured and this temporoparietal junction can be sharply demarcated over the skull, right? Yeah. So this is what is about etiology. So now what we will do is let us concentrate on the events after the head trauma. What generally will happen, we will concentrate. So we'll move on to the pathophysiology of the condition, right? So what generally happen here is first there is a head trauma, right? Head trauma. Generally the head trauma, usually if it is severe, then only there will be a fracture of the skull. If the head trauma is not so severe, then we won't see the fracture of the skull. In such condition, we won't see the epidural hematoma also. Head trauma, if it is severe, concentrate on these points, guys. If it is severe, then what will happen is, then we will see the skull fracture, right? Then we will see the skull fracture. What is the most common bone to get fractured? Temporal bone, right? So because of the skull fracture, that is temporal bone, which artery is going to be affected in this condition or ruptured? What would be that one? It is the middle meningeal artery, right? It would be the middle meningeal artery. So because of the rupture of the middle meningeal artery, there will be a formation of the hemorrhage or hematoma. So because of this, what happens is there will be increase in the intracranial pressure. So this point is very, very important in the pathophysiology. So what will happen because of the epidural hemorrhage or the hematoma? There will be increase in the intracranial pressure. So whenever there is a too much increase in the intracranial pressure, what will happen is the brainstem structures, that is pons, especially the medulla oblongata, it will herniate through the foramina magnum and there will be uncal herniation. So because of increase in the intracranial pressure, there is a too much pressure exactly over the brainstem structures. What we will see over here will be third cranial nerve palsy. Concentrate on this point. Third cranial nerve palsy. Concentrate on this point. Third cranial nerve palsy, mainly because of the uncal herniation. So what will happen if there is a third cranial nerve palsy, guys? So what is the symptomatology you are actually expecting in this condition? Whenever there is a compression of the third cranial nerve, what is it? It is the oculomotor nerve, right? So whenever there's a compression of the oculomotor nerve, that results in the failure or the paralysis of the iris sphincter muscle. So concentrate on that point also over here. So iris sphincter muscle. So iris sphincter muscle is going to get compromised. Iris sphincter muscle. If the iris sphincter is not working, then what would be the condition? Dilation, right? So that is how you have to remember. So, and remember this point, this iris sphincter muscle is innervated by what fibers? Innervated by parasympathetic fibers. So whenever we are discussing about any condition, guys, you should know in and out of this topic. Then only you can remember for long term. Not only that, you can repeat it also without much revision. So don't just by heart the concepts, rather than try to understand why these are happening, because every event is connected to another, right? Yeah. So till now, whatever we discussed about the traumatic causes, which means the trauma is responsible for the development of the fracture of the temporal bone that leads to medial meningeal artery rupture, and that leads to formation of the hemorrhage and hematoma. And sometimes there will be non-traumatic causes also. So let's appreciate that point here. Non-traumatic causes. Non-traumatic causes. So even though it has less important clinically, but it is important to know what would be the non-traumatic causes of the epidural hematoma, even though they are rare. There will be, the first one will be congenital AV arteriovenous malformations that may lead to the development of epidural hematomas, or infection or coagulopathy, right? Concentrate on these points pretty clearly. Congenital arteriovenous malformations, infection, coagulopathy, epidural abscess, epidural abscess, epidural abscess, or maybe sometimes due to the complication of the neurosurgical procedures, even though it is rare. So all these are considered to be the non-traumatic causes, right? All these are considered to be non-traumatic causes, even though they are rare. Just as a point of interest, just remember these points. Yes. So we completed the epidemiology, etiology, as well as the pathophysiology, which means how there will be an oculomotor nerve palsy that leads to the paralysis of the iris sphincter muscle because of the head trauma, how the intracranial pressure is going to get increased. We know that concept pretty clearly now. Let us concentrate more on the clinical manifestations, right? Because clinical manifestations actually gives you the real clinical picture of the condition. So let us concentrate on clinical manifestations. Clinical features. Let us concentrate on these points. So what are the clinical features? Remember, whenever the head trauma is very severe, we know that that results in epidural hematoma. But when epidural hematoma is developed, in most often what we see is loss of consciousness. So generally this loss of consciousness and going into coma depends upon the severity of the impact. If the impact is very severe and there will be a massive hemorrhage or hematoma, then there's a chance of the patient is going into the coma immediately. But if there is a less severe injury, in such condition what will happen? But there is a rupture of the middle meningeal artery. In such condition, even that produces epidural hematoma, but there will not be coma, but there is only a momentary loss of consciousness. So what is important points we need to write here is, if injury is very severe, if injury is very severe, and if the injury is mild, or we can say better to mention less severe instead of saying mild, okay, less severe. In such conditions, what will happen? If it is very severe, the patient may go into the condition called as coma, or even it leads to death. Spontaneous death may happen, right? If the injury is very, very severe. And if the injury is mild, there will be only momentary loss of consciousness, right? momentary loss of consciousness. Concentrate on this point very clearly. So why we are calling it as a momentary loss of consciousness? Because so suddenly he fell down because of an assault or from the bike, and there is a sudden impact to the head. So then what will happen? He may be going into the state of unconsciousness for a certain period of time. After that, there will be a regain of the consciousness. That's why I mentioned the point very clearly, stating that there will be a momentary loss of consciousness. Because of that impact, it's not because of the hematoma per se, it is because of the sudden impact to the brain. So he lost the consciousness. But after that, what will happen after 5 minutes or 10 minutes or during the time, the consciousness has been regained, then he has taken to the hospital, or maybe thinking that the impact is not so severe, he went to his home. But after that, what will happen is after 2 to 3 hours, his condition gets deteriorated. Why his condition gets deteriorated? What do you think? It's mainly depend on the extent of the bleeding. So concentrate on this point very clearly. So what happened? There's an impact. Momentary loss of consciousness is there. So after the momentary loss of consciousness, he regained that consciousness, and after that, there is a 2 to 3 hours of time. The bleeding is continuous, and there will be a continuous bleeding, and hematoma is expanding. So as the hematoma is expanding, it is going to compress the brain parenchyma, that is brain structures. In such condition, there will be a deterioration of condition. So remember this point very clearly. If the hematoma is very, very severe, then what will happen? During the 3 to 4 hours of time, suddenly he may lose consciousness, he may go into the state of coma, and sometimes may lead to death also. So remember, the patient may show a rapid progression that leads to coma and death within hours, or maybe if the impact is very severe, death may happen within minutes also. But in some patients, that is with acute epidural hematoma, if the injury is less severe, so what is the terminology we used here? We said that there is a momentary loss of consciousness, which means transient loss of consciousness. So after that, there is a period. I mentioned about the period, right? That period is called as lucid interval. Remember this terminology. What is this? Lucid interval, right? Concentrate on this point, lucid interval. So there is a loss of consciousness, momentary loss of consciousness. After that, the time period is called as lucid interval with recovery of consciousness, and followed by the deterioration of his condition over a period of time. That may be hours also, right? That is mainly because of continued arterial bleeding and expansion of the hematoma. So this is called as lucid interval. So whenever his condition is getting deteriorated, right, this deterioration of the condition is typically associated with certain symptoms. What are they? We are going to discuss now, right? So whenever there is a deterioration of his condition, right, let us write that point. Deterioration of epidural hematoma after the lucid interval. So what will be the clinical manifestations or symptomatology we will see here? There will be more commonly headache, vomiting. These are pretty most common clinical manifestations we generally see whenever his condition is getting deteriorated, and slowly he'll go into the state of drowsiness. He'll go into the state of drowsiness, and there will be a state of confusion also. Remember this point, confusion, right? There will be mental state is not proper, in the state of confusion, and aphasia, right? There will be aphasia, or sometimes if condition is a bit more severe, he may develop seizures because of the compression of the brain parenchyma. Seizures, and sometimes we may also see hemiparesis also, right? So concentrate on these points, guys. So all these events are considered to be right? Deterioration of the patient's condition, headache, vomiting, right? Drowsiness, confusion. So all these we are seeing aphasia, seizures. So all these are seen whenever his condition is getting deteriorated. Okay, so that is what we have to concentrate here. So do you remember the point I mentioned about after the lucid interval there will be a continuous expansion of the hematoma? Because of the hematoma expansion, I told you that there will be a deterioration of the condition, right? So generally what will happen if the hematoma is unchecked? If the hematoma is unchecked, what will happen? There will be expansion of epidural hematoma, right? Expansion. So because of the expansion, what will be the condition? Elevated intracranial pressure. So there will be elevated intracranial pressure, right? So concentrate on these points. So elevated intracranial pressure. So because of the elevated intracranial pressure, what will happen? The sphincter muscle, the iris sphincter muscle is not working. So there will be an ipsilateral dilated pupil only when there is an uncal herniation due to the compression of the oculomotor nerve. So what I will write is there will be, because of increase in the intracranial pressure, there will be uncal herniation. So because of this there will be compression, right? Compression of the third cranial nerve. So because of this what will happen? There will be ipsilateral dilated pupil, right? So because of this what will happen? There will be ipsilateral dilated pupil. Concentrate on this point, especially because of uncal herniation, because of compression of the oculomotor nerve. And in such condition, if the hematoma expansion is very severe and if the intracranial pressure is more, and we could also see a event called as Cushing's reflex. We'll also call it as a Cushing's triad. Okay, let's concentrate on what is the Cushing's reflex. So what is this Cushing's reflex, guys? It has a triad. Initially there is an hypertension. Later there is a development of bradycardia. And also at the same time we will see respiratory irregularity or respiratory depression. So what are the three events we will see in this triad? What are the three events? First, hypertension. I'll explain you in detail also why there is hypertension first, and after that why there is a bradycardia, right? Yeah, first hypertension. Second, there will be bradycardia. And next we will see respiratory depression or respiratory irregularity. Respiratory depression or respiratory irregularity. So this is what we call it as the Cushing's reflex. So see here, whenever there is an increase in the intracranial pressure, there will be a decrease in the perfusion pressure within the brain. Right? Concentrate on this point. Whenever there is an increase in the intracranial pressure, there will be a decrease in the perfusion pressure within the brain. So because of this, what will happen is a compensatory mechanisms play in role. So what will be the compensatory mechanism? The compensatory mechanism will be increase in the heart rate, right? So mainly to increase the cerebral perfusion, as sympathetic nervous system activation can be seen. So there will be activation of sympathetic nervous system. Remember, there will be activation of sympathetic nervous system mainly to maintain the cerebral perfusion. So whenever sympathetic nervous system gets activated, So what will happen here? There will be increase in the systolic blood pressure, right? Systolic BP. There will be increase in the systolic blood pressure. So whenever there is an increase in the systolic blood pressure, what will happen is the aortic arch has a baroreceptors. So whenever the pressure is increased, these baroreceptors will detect the pressure. So whenever they detect, they get stimulated. So the stimulation of the aortic arch baroreceptors responsible for the activation of the parasympathetic nervous system. So what will happen whenever there is an increase in the systolic blood pressure? What will happen? There will be stimulation, right? Stimulation of aortic arch baroreceptors. Aortic arch baroreceptors. So due to this, there will be activation of parasympathetic nervous system, right? Parasympathetic nervous system. So when parasympathetic nervous system gets activated, right? When parasympathetic nervous system gets activated, so what will happen? There will be bradycardia because of the vagus nerve. So there will be stimulation of the vagus nerve, stimulation of vagus, that leads to bradycardia. Now, did you understand why there is hypertension first as well as bradycardia later? Initially, as a compensatory mechanism, activation of the sympathetic nervous system, there will be hypertension, increase in the systolic blood pressure, and detection of the high pressures in the aortic arch baroreceptors. So stimulation of the aortic arch baroreceptors causes stimulation of the parasympathetic nervous system, that is vagus nerve activation, causes decrease in the heart rate, that is bradycardia. So in the triad, now you know the two events, why hypertension and why there is a bradycardia. Now, we should also know why there is an irregular breathing. So if you remember about the physiology of the respiration, that is regulation of the respiratory rate, you might have studied about the respiratory centers which are present in the pons as well as in the medulla oblongata, right? So these are the brainstem structures. So whenever there is a increase in the intracranial pressure, there will be a too much pressure on the brainstem. So whenever there is increased pressure on the brainstem, concentrate on this point, increased pressure on brainstem. So whenever there is an increased pressure on the brainstem, so what will happen? There will be a dysfunction of the respiratory center. So respiratory center dysfunction. Respiratory center dysfunction, that leads to irregular breathing or respiratory depression. Now, did you understand why there is an irregular breathing as well as a respiratory depression over here? Yes, it is mainly because of the compression of the brainstem structures, especially the nuclei, apneustic center, pneumotaxic center. These are the centers of the respiratory centers, right? We have various centers of respiration in the physiology. We studied about it. Because of this, there will be irregular respiration, irregular breathing, or respiratory depression. So this is what is called as the triad of the Cushings, right? Yeah. Now let us concentrate on diagnosis. So we'll write the diagnosis here. What is the diagnosis? Remember, generally in the neurological events, we often perform the lumbar puncture, but remember, lumbar puncture in this condition is purely contraindicated. Not only in this, any space occupying lesions, right? Whether it is epidural hematoma or any space occupying lesion, subdural hematoma, whenever it is suspected, because of the risk of herniation, lumbar puncture is contraindicated. So remember, in the diagnosis, we are not going to perform lumbar puncture. Then what will be the imaging of choice here? That is what the examiner is going to ask. Imaging of choice. So what will be the imaging of choice? It will be non-contrast head CT scan. Remember this point. Non-contrast head CT scan, right? So this is considered to be the imaging of choice. Remember this point. Non-contrast head CT scan is considered to be the imaging of choice. So this computer tomography CT of the head is the most widely used imaging study for the acute head trauma, mainly because of its speed, it's because of relative simplicity and widespread availability. So because of these reasons, mainly this is considered to be the imaging of choice. And remember a point that most of the epidural hematomas are identified on the CT scan, right? Most of the epidural hematomas are identified on the CT scan. So what are the findings we generally see on the CT? So let us see the CT scan findings over here. So can you see the beautiful image here, which clearly shows the biconvex hyperdense lesion? Yes, we can see. It is clearly biconvex, right? And it is a hyperdense lesion. And where it is located? Between the brain and the calvarium, and it is limited by suture lines. Remember this point. So whenever the hematoma is limited by suture lines, it is epidural. If it is not limited by suture lines, it is subdural hematoma. So this is what you have to remember about the difference between epidural hematoma as well as the subdural hematoma, right? So this is limited by the suture lines, and subdural hematoma is not limited by the suture lines. Now, so what is the another imaging modality we have other than the CT? Yes, we have MRI, right? So another imaging modality is MRI. So MRI has a higher sensitivity. Higher sensitivity. So even though it is higher sensitivity when compared to that of CT, so why are we not using this? I already mentioned about three important points: because of speed, because of availability, because of simplicity, because of cost, everything. So even though the MRI has a higher sensitivity, it is slower. That is a very, very important. That is slower when compared to that of the CT scan. So that's why making it unsuitable, especially for the unstable patients, because you need speed at the time, mainly to diagnose. So we cannot use MRI for the unstable patients, even though we have a higher sensitivity with this. And remember that another important thing is it is not also widely available in all the hospitals, right, when compared to the of CT. So that is the another reason that this MRI is not considered to be the imaging of choice. But remember, if there is a strong suspicion of the epidural hematoma, but if no hematoma is visible on CT, concentrate on this point very clearly. If epidural hematoma or hematoma is not seen on CT, concentrate on this point, then what you will do? Yes, of course, you have to go with MRI. Remember, if the hematoma is not visible on CT, and MRI may be used at that point mainly to conclude the diagnosis. Now, so here, as I already mentioned, I want to repeat the point once again regarding the key differences, because in the screen you can see two images separately showing the epidural as well as the subdural hematoma over here. So the key differences between the subdural hematoma and the epidural hematoma are readily demonstrable mainly by the unenhanced computer tomography of the head. That is what we are seeing here. Remember, epidural hematoma does not cross sutural margins but cross dural attachments, mainly because it is located in the potential space between the dura as well as the skull. And another important feature you can identify in the epidural hematoma, that this epidural hematoma has a lens shaped appearance. Can you see this lens shaped appearance? But on the other image, you can see the subdural hematoma in comparison. It can cross sutural margins, but it is limited by the dural attachment. So there is a clear-cut differences between these two. So this is limited by the dural attachments, but not limited by the sutural margins. And that is the reason you can clearly see a crescentic shaped extraaxial lesion, right? Lens shaped is the epidural hematoma, crescent shaped is the subdural hematoma. This is the important the radiological difference, because in the radiology also this is what we are going to discuss. This is the main difference between the epidural as well as the subdural hematoma. Now, so let us also concentrate on another image, concentrate on the MRI here, the brain MRI. So we already mentioned that the CT is most widely available, and the brain magnetic resonance imaging is more sensitive when compared to that of the head CT scan for the detection of any type of intracranial hemorrhages. But remember the point that MRI is especially useful in the diagnosis of epidural hematoma at the vertex, right? This is the point you have to concentrate. And you can see the MRI signal appearance of the epidural hematoma and subdural hematoma evolves over time in a manner similar to that of observed in the parenchymal hematomas. So that is an important point we need to consider over here. So let us see the MRI pictures here, how it can be differentiated. First, this is the image where you are seeing the acute clot. So remember, this acute clot is always hypointense on T2 weighted images on the MRI. Remember the point very clearly. Whenever the clot is acute clot is hypointense on T2 weighted images, mainly due to the presence of deoxyhemoglobin. Remember, because of the presence of deoxyhemoglobin, so the acute clot is hypointense. So over the subsequent weeks, generally what happens, the deoxyhemoglobin concentration is going to decrease because the deoxyhemoglobin decreases to methemoglobin, right? So after this, it appears bright on both T1 as well as T2 weighted images. That is what you are seeing in this picture very clearly, right? Because the methemoglobin is formed because of the degradation of this, there will be hyperintense on both T1 as well as on the T2. And after several months, what will happen is only hemosiderin remains. After several months, remember this point, only hemosiderin remains. And the clot again going to become hypointense on the T1 weighted images. So this is how you can see the differences over the time, right? Now, another important diagnostic modality what we have is the angiography. So I don't want to write about this point here, but let's discuss about the angiography. Angiography is only performed under unusual conditions. Remember guys, it is not performed routinely as a protocol, only under unusual circumstances. We generally often call it as the cerebral angiography, is mainly indicated for the evaluation of EDH. For example, as an example, if the EDH is located at the vertex, can originate from the dural arteriovenous fistula of the middle meningeal artery. In this particular setting only, the angiography is necessary, mainly to fully evaluate the possibility of an underlying vascular lesion. So mainly to identify the underlying vascular lesion fistula if it is present. Mainly for that we are going to perform this angiography. Otherwise routinely we are not going to perform this one, right? So this is what you need to know about the diagnosis. Next, let us concentrate on prognostic indicators. This is also very important guys. Prognosis. Prognosis, that is prognostic indicators, right? The first important thing, because in an observational studies we have like different points which are associated with the unfavorable outcomes of the epidural hematoma. So what are the unfavorable outcomes? Let us concentrate here. Let us concentrate on those points. The first one is the low GCS score. Glasgow Coma scale, we know this. So whenever low GCS score on admission or before surgery, concentrate on this point. Whenever we find low GCS score on admission or before surgery, right? So this GCS grades actually the coma severity according to the three categories of responsiveness, like best eye opening, best verbal, and best motor response. So based on this we actually score, even though it is a separate concept. But remember at this point that low GCS score has unfavorable outcome. Generally, the GCS is scored between 3 and 15. Higher scores indicating better performance, which means better prognosis. That is what we need to concentrate. Next, another important prognostic marker will be presence of pupillary abnormalities. It also has a low prognostic indicator or low prognosis. So, pupillary abnormalities. So whenever we talk about pupillary abnormalities, particularly we often find the contralateral or the bilateral unreactive pupils. So whenever we find this, yes, it has an unfavorable outcome, or we can say an indicator of bad prognosis. Another important prognostic marker will be the age. The third important prognostic marker will be the age. Greater the age and lesser will be the prognosis. So older age, that is greater than 75 years, has unfavorable outcome. And another important thing will be time gap. What do you mean by this time gap? So whenever there's a longer time interval between the neurological deterioration and the surgery, right? So neurological deterioration and surgery. So if you have more time between the neurological deterioration and the surgery, and that is the time gap, more time gap, less will be the prognosis, right? And next will be, another important will be, so after surgery, if there is a post-operative elevated intracranial pressure, then also it is considered to be the unfavorable outcome. So post-operative increase in the intracranial pressure. So concentrate on these points, guys. Low GCS scores, right? So what are the unfavorable outcomes? Low GCS scores, pupillary abnormalities, right? So presence of the pupillary abnormalities, age greater than 75 years, time gap, that is more time between the neurological deterioration of the condition as well as the surgery, and post-operative increase in the intracranial pressure. So all these have unfavorable outcomes. Okay. Now let us concentrate on more points regarding this. In addition to all of these things, whatever we have studied till now, so we also have some more points, which means several studies which have identified by means of the CT findings that correlates with a poor outcome, mainly by means of CT findings. So what they are, another point will be, whenever you find a hematoma volume which is greater than 30 to 150 cubic centimeters. So hematoma volume. So remember, whenever it is greater than 30, right? Whenever it is greater than 30 to 150 cubic centimeter, considered to be a poor prognostic indicator. And whenever you find a midline shift that is greater than 10 to 12 mm, seventh point, whenever you find midline shift that is greater than 10 to 12 mm, considered to be a poor prognostic marker. And also whenever you find a mixed density blood clot. So what is the meaning of mixed density? High density, low density, which means what? One is a hematoma, one is a hemorrhage in combination, indicating active bleeding. So whenever we have a mixed density blood clot, then also it is considered to be having a poor prognostic marker. Other than this, whenever we have other pre-existing conditions, or maybe the conditions associated with intracranial lesions, such as like contusions, whenever we have like intracerebral hemorrhage in this patient, or maybe the patient is also having a subarachnoid hemorrhage, or maybe because of the diffuse brain swelling. All these other than this can be considered as a poor prognostic indicators. So this is what we need to know about the prognosis. Let us talk about the management part here. So what would be the initial management here? Initial resuscitation, what we have to do. If hypotension is present, we have to administer IV fluids. And very important is to stabilize the patient condition. So intubation need to be done. But what would be the first line of treatment? Remember, surgery is considered to be the first line. So in the management part, what I will write here is, let's concentrate on what is the first line, surgery. Remember, as a management part, surgery is considered to be the first line. Very important point. First line is the surgery, that is urgent craniotomy and hematoma evacuation should be done. Because after cutting the cranial bone, and hematoma should be removed mainly to decrease intracranial pressure and to prevent the midline shift and to prevent the uncal herniation and to prevent the respiratory depression, mainly to prevent the deterioration of his condition. That is, the patient may go into the state called as coma, and that may lead to death. That's why so urgent craniotomy and hematoma evacuation should be done. So that's the reason surgery is the first line, that is urgent craniotomy and hematoma evacuation. Right? Concentrate on these points, guys. Urgent craniotomy and hematoma evacuation, mainly to prevent deterioration of his condition. So that's why we generally often we say in this condition that craniotomy and hematoma evacuation is the mainstay of surgical treatment in symptomatic acute epidural hematoma, right? So we know this by seeing this symptomatology. By this time we should know that this acute symptomatic epidural hematoma is a neurologic emergency, right? So that's why that often requires surgical treatment, mainly for what? To prevent irreversible brain injury, that is brain damage, and to prevent death, which is caused by the continuous expansion of the hematoma, elevation of the intracranial pressure, and herniation of the brain. So this is considered to be the first line. So whenever we speak about the first line, what would be the second line? Think about this point. Emergency burhole. Concentrate on the wordings over here. Emergency burhole. So what is this? What do you mean by this emergency burhole? So this procedure actually consists of drilling one or more holes in the skull, mainly to drain as well as evacuate an epidural as well as subdural hematoma. So remember that this is actually a life-saving procedure, right? So why it is life-saving procedure? Why are we using this? We said that surgery is the mainstay of treatment. It is the first line. But why are we using the terminology called as it is a life-saving procedure? Because this emergency burhole can be performed by the general surgeon also. There is no need of a neurosurgical expert, because if you don't have a neurosurgical expert or neurosurgical care, then general physician can perform burhole procedure mainly to evacuate the hematoma. So that's why it is a life-saving procedure, we can say. But as a protocol, surgery is considered to be the first choice, that is urgent craniotomy, right, and hematoma evacuation, and second line of treatment. That's why we say second line is called as emergency burhole. And remember at this point, whenever we talk about medications, generally we in majority of the neurological conditions, for many conditions we give glucocorticoid therapy. But remember, glucocorticoid therapy is not indicated of any head injuries, following any head injury, because that may be associated with increased acute mortality. So remember, not only in this condition, whenever we talk about any head injury, acute head injury conditions, glucocorticoid therapy is purely not indicated. Now So the first line as well as second line of treatment is okay, but let us concentrate on the points. How do we manage the elevated intracranial pressure? So management of the elevated intracranial pressure mainly done by head elevation, and if the patient is already intubated, right, then hyperventilation and osmotic diuresis with mannitol or hyperosmotic saline solution can be administered, right? This is what we can manage the elevated intracranial pressure. So sometimes we also have the non-operative management too. So what is the non-operative management of acute epidural hematoma? So non-operative management includes a very close observation as well as a serial brain imaging, because there is a risk of development of hematoma enlargement and there is a condition of neurological deterioration that requires a surgical intervention. This is nothing but called as non-operative management. That's the reason the clinicians who are seeing these patients are recommended obtaining the first follow-up head CT scan. That's why we called it as the imaging of choice. Later 6 to 8 hours after the head injury, continuously, even if the hematoma is not expanding also, you don't know if the condition is not deteriorated, so you keep on taking the head CT scan for every 6 to 8 hours. If hematoma is not expanding well and good, then but still you have to perform surgery because to remove the hematoma in such patients. Now let us concentrate on few images here, because by seeing these images we can appreciate whatever we have discussed till now, and the same images are also going to come in your radiology MCQs also. So this is a beautiful image. What we are seeing is the epidural hematoma, right? So this is a very large temporal epidural hematoma which is mainly associated with the midline shift. Can you see the midline shift here? Yes, we can see the midline shift very clearly. And also we can see the compression of the ventricular system. So that may lead to the hydrocephalus also, right? So we can see the midline shift in this image, as well as we can see the obstruction of the ventricular system, which means the patient condition is pretty serious. By seeing this, we can say, along with this, if you closely examine, we can also see the dark swirls within the hematoma. So what does the dark swirls represent whenever it is present inside the hematoma? It always represents rapid arterial bleeding. This is called as swill sign, which means intracranial hemorrhage, called as swill sign. So this swill sign, what we are seeing here, refers to the non-contrast head CT appearance of acute extravasation of the blood into the hematoma. For example, an extradural hematoma or subdural hematoma, in any condition we can see the swill sign. So this actually represents the unclotted fresh blood which is of lower attenuation than the clotted blood which surrounds it. So remember, this is what is called as swill sign. So it is the corollary of the spot sign on the CTA which actually represents the same phenomena, but in that case it is caused by the contrast extravasation. So that difference you need to know in terms of radiology. Now, so here we can see another beautiful image of a 19-month-old was presented after falling down from height. And here in this image we can clearly see a pretty large epidural hematoma which can give an appearance of lens-like appearance, which we already discussed about it, or we could see a pretty clear biconvex shaped in the temporal location, which is pretty much represented by arrowheads. And also we can see the heterogeneous appearance indicating an active bleeding. I already mentioned about active bleeding within the hematoma explains the swirl sign, right? This is the hemorrhage that is also represented by an arrow mark here. And in this patient, because of the hematoma is pretty large, what would be the complication, guys? The complication will be elevated in the intracranial pressure with the absence of sulci, and also we can clearly see the dotted line which clearly indicates the midline shift, and also the compressed right ventricle which is represented by the curved arrow over here. So all these are giving an indication of poor prognosis of this condition, right? Now, this is another image. What we are seeing is a traumatic epidural hematoma in this patient. This is another image. We can clearly see a lenticular shaped epidural hematoma here. And there is another image also we could appreciate, which is the posterior fossa epidural hematoma. right? So in this condition, by seeing the image itself, we can say there's a rapid deterioration in previously awake patient. Why are we calling it as a previously awake patient? Because of the lucid interval after 3 to 4 hours, because of the active bleeding and expansion of the hematoma. There will be a deterioration of his condition. That's the reason. That is what the case we are seeing here. There's a rapid deterioration of the patient condition. In previously awake patients with this type of injury is a very major concern, because this is associated with a poor prognosis. And we can also see a temporal skull fracture with an intracranial bleed in this image, in another image over here. So we could appreciate the skull fracture in the left temporal region, which is associated with the presence of epidural hematoma, and the CT image has obtained using a brain windows, which clearly shows the lentiform epidural hematoma, which is represented by a star mark over here, especially in the left frontal region. And I hope you can notice carefully by seeing this image that we have a superficial hematoma as well as gas in the left temporal region, which can be clearly demarcated by arrow marks, and also there is a compression of the left lateral ventricle, what we can see here, right? Now let us also see one of the image associated with MRI of the brain. So this is the MRI of the brain, which demonstrates a traumatic epidural hematoma in the left parieto-occipital region. You can see here, which is represented by arrow marks. And let me show you another image, because I want to show many of the images, so that whenever you see different types of images in the exam, you should be in a position to identify those images pretty quick time. So this is another image which clearly shows a massive biconvex extradural or the epidural hematoma. Here also we can see the shift of the midline, right? There's a massive biconvex extradural hematoma which is associated with the skull fracture, even though we cannot able to see the skull fracture over here, which is resulting in a marked midline shift. You can clearly see the midline shift in this image, as well as the hydrocephalus of the left lateral ventricle, mainly because of the obstruction. We can clearly see a slit-like appearance in this image, but its outflow is completely obstructed. So that is what we need to know about the images of the epidural hematoma. So by this we completed the topic called as epidural hematoma.